interest of time. Good morning, good afternoon, everyone. Thank you so much for joining. This is our third session for our global cancer um, healthcare. Oops, my mistake. Healthcare Provider Support Quality Improvement Echo, um, session 3 of 4. So if you are a returning participant, welcome. If you are brand new, welcome. We're so excited to have you all today. I'm just going to do a little bit of housekeeping before we get started into today's session. So each of these Echo sessions will be recorded and posted to our publicly facing ACS Echo website. If you do not want your video to be shared, go ahead and turn that video off. However, we really do encourage, if you're comfortable, to share your video, so that way we can really create a sense of community and we can feel like we're talking to each other instead of black squares. You can use the buttons in the black menu bar to mute and unmute your line or turn off your video at any time during the meeting. If you are calling in, you are able to use *6 to mute and unmute your line. If you have logged in to the Zoom session under somebody else's name, please go ahead and change the your participant name to your first name, last name, and country. You are able to do this by going into by clicking the participants list, going to your name, choosing the 3 dots, and then hit rename. This will make sure that we're able to count you as attending today's session and that you're not and that you're under your name. In general, during any of these sessions, we do not share any public or personal health information about any patient. So please be mindful when sharing your experience or your background. And if you have any questions, you can always feel free to chat us in the chat box or feel free to come off mute and join. We're very open in these sessions. So we do welcome, engagement of any type. So just a quick overview of the agenda for today. We have a 90-minute session where Paulette is going to provide us some recap and kind of figure out who's in the room. Gannett is going to do an overview of the Treat the Pain. We have Vedest here to give us a great didactic on the Rwandan example of implementation. And then we're going to have 2 case studies that we received that were anonymous to really then the case studies are the heart of our Echo series. So we really want to make sure that we have a good amount of time to engage in that discussion and have an opportunity to share some of the challenges your colleagues have been having and for you to share your own experience and recommendations as well. And then we will wrap up. And again, if you have any questions or if there's something you want to ask, feel free to enter it in the chat and then we can make sure it's addressed. Or when we get to any of the Q&A portions or the open discussion portions, feel free to come off mute and join in that way as well. And with that, I will turn it over to Paulette to give a brief recap of the previous session and some of the overview of what to expect for what's coming up. Paulette?
Awesome. Thank you, Rish. Thank you so much for the intro. And thanks, everyone. I can't believe we're already on the third, which is amazing. And I hope that the last 2 sessions have been, you know, actually like the last 2 sessions have been really helpful. And again, what we're doing with these sessions is reinforcing what you're already doing at your facilities. Again, figuring out how to strengthen the global cancer care by supporting everyone on this call, every provider, it doesn't matter what your role is, and your institutions with access to practical resources and tools that improve patient outcomes, because ultimately that's what we want to see. We want to see those values improving. So over 3 months through various learning opportunities, we're going to be, doing provider-led evaluations and feedback. Next slide, please. All right, so basically, we have in the last session, we looked at the NCCN guidelines, which are a product of a a collaboration between the African Cancer Coalition and NCCN. And so these are um, over 56 cancer treatment guidelines that are adapted to our unique needs in low resource settings in sub-Saharan Africa. You know, whether we have, a CT scan or whether we have, enough surgeons. So again, it is by us, for us, in collaboration with our very amazing partners from ACS and NCCN. And so, again, it was a really fantastic session where we had um, Rinty and Dr. Lekong, who are, very well versed in this, just really helping us to appreciate um, what goes into the guidelines, how to use it, and we had a really rich conversation around what some of the challenges are and solutions, and then we got feedback from several people on the call. So again, this map sort of shows us the number of healthcare providers from each of the countries listed here who are part of the ACC. We see some countries have more than others, but definitely what you're seeing in one region is certainly what you're seeing in another as well. Next slide, please. All right. And so then we also then moved to just again some of the things that I just talked about, right? So there are over 56 guidelines. There are participation from several folks. And fortunately, we see that there's been over 100,000 downloads, which suggests that we're using them. So let's keep doing that. Again, the goal of the of highlighting the guidelines is that we know it's there, we use it, but more critically, that we're making sure that as we develop treatment guidelines and as we're providing care, we're aligning with what the guidelines say is great. And I think one of the things that a lot of providers have said about the guidelines is that there's that section where there's room to annotate, to give feedback, to say, hey, look, in my center, this is even more appropriate or not. And we can go from there. So again, thanks everyone who has participated. What we're trying to make sure here is that our policymakers and our providers are aware of the guidelines and what goes into developing them. And we want to know, we want to make sure that the hospitals and the providers are using them, and what are the ways we can support, and how can ministries and hospital leaders and providers respond to these guidelines. We heard from Dr. Uche from um, Nigeria last in that session, communicating that in the capacity of his role in the ministry, he was able to insist that their MDTs and the guidelines are part of what are used. And again, fortunately, Nigeria has endorsed them, so they're used. And so, again, thank you to everyone who's downloaded, participated, and then we're going to go into today's very rich conversation about access to payment. Next slide, please. But before we move forward, it would be great to know who is on the call. So, like the last time, just give an emoji that's associated to your country. For Nigeria, it's a thumbs up. For Ghana, it's a celebration emoji with a party hat. For Ethiopia, is a heart sign. For Rwanda, it's the clapping emoji. Just let's know who's here and start to um, get a sense of who's contributing to the conversation, who's listening, and again, just to get a sense of who's here. And if none of these countries represent who you are, we recognize that there might be people here from ACC who are not part of the current Global Academy plan. Just give us a smile, give us a smiling emoji if that's the case, and then also let us know in the chat, or just change your name, including what country you're from. Laura, do we want to do the poll now before we bring Annette? Awesome. All right. While I see folks are giving us the thumbs up and the emojis, we have a number of poll. We have a poll up now. We just really want to also get a sense of who's here. Unlike the last time where we're going a question at a time, all questions are here. So if you can just scroll down as well, you see other questions. The first is we want to understand your role in your institution. Then we want to, hear your feedback on consistent supply of analgesics in your hospital. The third question is around, how you regularly assess patient pain, if that's happening. The number four is, do your colleagues also regular assess pain? And then finally, are you concerned about the level of patient pain in your hospital or ward? So if you could just go through, just scroll down, you'll see the questions. We see people are responding. We have about 35, a little under 40, and I see we have over 80 people on the call. So please, um, yeah, please respond. It helps us to get a sense of who's here on the call. So we have about 42 people responding. We have close to 80 people on the call. So if we can get more people responded, that'd be great. Thank you. We'll keep it up for another 30 seconds or so. If you can respond, that would be great. Awesome. We see different people on the call as well, still using the emojis. Thank you. You can keep that up even while you respond to the questions. We have about 50 people responding of the almost 80 people. Just a couple more seconds and we will move on. This is great. Thanks, everyone. Great, great. We're getting to 52. Awesome. It's definitely more than half of everyone who's on the call. So I think that's a good place to stop so that we can move on and see what those yeah. Laura, do you want to keep this on for a little bit more or do we want to stop? What do you think?
I'm sharing the results.
Awesome. Awesome. Okay,
I hope.
great. Thanks. Fantastic. So we see what the results are here. If you scroll, you can see them as well. But real quick, I see that, we have mostly doctors here and then nurses, pharmacists, and then quite a number of palliative care specialists, about three people who identify as palliative care specialists, which is great. We see that, there is some availability of analgesics, about 63%. Folks are regularly assessing their patient's pain level, see their colleagues doing so, although there's a bit of a drop there, and we actually have a significant maybe as well. Um, then there's still concern about the level of pain that patients have, which is, it's good that we're concerned about that, which explains why we're on this call, and hopefully we can learn from each other. Awesome. Okay. I think we can stop sharing the poll and move on. And I have the very excellent pleasure of introducing our next guest. We have Gannett Neguse, who is a program manager with ACS. Gannett has being with the American Cancer Society, where she leads the global health provider support through training and capacity building initiatives. She's previously also served as a program manager for the Pain Free Hospital Initiative in Ethiopia, where, part of the work there was training over 3,000 healthcare providers in pain management. And she was successful in transitioning all of that work to the Ethiopian Ministry of Health for long-term sustainability, which is what we want to see with all of the work that we're doing. And before joining the American Cancer Society, she worked as a health financing analyst with the Clinton Health Access Initiative and was seconded to the Ministry of Health to strengthen national health financing system. So thank you, Gannett, for this session and welcome. Over to you.
Thank you, Paulette, for the intro. Welcome, everyone. Thank you so much for being here today with us to listen what we have. Uh, all right. So in this session, we'll be discussing uh, about first is about the background of pain control in low and middle income countries. Then we will see shortly what ACS Global is currently doing to strengthen pain management through our flagship initiative, Treat the Pain initiative. Then we will be hearing from Rwanda, a very successful rollout for the last 6 years. Rwanda has managed to roll out Treat the Pain throughout the country. We will be hearing from them, which has a great lesson for most of us. And we have, as Rish mentioned, we have two cases to be presented. The cases are submitted from ECHO participants. We are very happy to see hospitals share their challenges and also the solutions they proposed. It's gonna be presented. And of course, we will have a discussion with you. We would love to hear from you about the challenges you have regards to pain management, also the best practice you have to share with your colleagues here, and any other question about what we do at ACS. That's really welcome. Thank you. To the next slide, please. All right. This data here is, as an ACS, it pushes us to do what we do. As you see from this data, access to opioid, which is the first line treatment for cancer-related pain, is critically insufficient in low and middle income countries. Unfortunately, low and middle income countries carry the biggest burden. 70% of cancer-related deaths occur in 2020 in low and middle income countries. But still, 90% of the morphine for pain relief is consumed in high income countries. The low and middle income countries use only 10% of the morphine for pain relief, but the population of low and middle income countries is around 82% of the world. So it's 18% of the world population use most of the opioid for like 90% of the opioid for pain management. And the reason for this is also well documented through different researches by WHO and the International Narcotic Board. Most of the challenges are the regulatory and legal barrier, limited supply chains, lack of training and awareness from healthcare providers, and stigma and fear and of misuse from patient side as well as from the healthcare provider side. Next slide. Here is also another interesting data to look. It's about access to palliative care services. Still, palliative care services are very, as we know, vital for patients, cancer patients, as well as other non-communicable disease patients. Still, high-income countries met their need. 70 to 80% of the need has met. But when we see, in contrast, the low and middle income countries, it's below 20%. Looking forward, also, WHO has estimated by 2037, nearly one-third of the global need for palliative care will be in Africa. That is driven by increase in cancer cases, as well as the HIV and other non-communicable diseases will be increasing, but the service still lacks. So as pain management is one of the big major component of palliative care, we as American Cancer Society work to alleviate most of the barriers. Next slide, please. Yeah. So for the last 10 plus years, we have, as ACS, most of you may know us from Pain-Free Hospital Initiative. We have worked in Ethiopia, Nigeria, Rwanda, Kenya, Tanzania, and 10 plus countries, mostly by providing training in the healthcare providers training. One is one of the major initiative we have. Also, we were advocating for policy for like countries to have a guideline, pain management guideline, as well as to include pain medicine in their uh, essential medicine list, as most of the pain medicines are essential, as WHO mentioned. Also, we used it to work on developing like low cost morphine production sites. We have supported Ethiopia, Rwanda, what's that? Uganda and other countries, Cameroon and other countries to have like a low cost morphine, local morphine production. We have trained more than 30,000 healthcare providers in basic training of like pain assessment and management. This is in 10 countries and also around more than 50 health institutions are covered to improve their pain management. Next slide. The ACS Treat the Pain program has resources for any healthcare provider who wants to improve their the pain management in their hospitals. We have like a well documented performance which shows like pain management can be implemented in low resource setting without high cost. So we had like we have advocating materials like to use for advocacy for essential medicines, as well as like other regulation to lose other regulation around access to pain medicine. We have also materials to assess providers' barriers for pain management. We have a training material, and we have like a lot of tools to use for evaluation of what you do, and then improving the barriers and integrating it to routine healthcare practice is a goal. So for advocacy, we have like case studies, policy reporting templates, since we have worked for the last 10 years, more than 10 years in different countries. Anyone who wants us to see other hospital performance, we can share that. Also, we have resources that are data collection materials for assessing what is the hospital knowledge and attitude level regards to the pain. And also we have a material to assess what's patient's pain score, average pain score in our hospital. If you want also to assess like what is my pain medication used for the last 3 months or for a last month, we have also some simple tools that can capture that will help. Also, we have a training material, which is one is self-learning materials, posters, job aids, which are very helpful. And also we have e-learning courses. Most of you may take our e-learning. It has 11 courses from introduction to pain, mechanisms of pain, pain assessment, and pain principles of pain management in adult and in children. Also, we have the survey tools to evaluate your performance. Anyone who wants these materials can contact us so we can provide. Thank you. Next slide, please. Yeah, with this, we're gonna transition to Vedaste Hatemana to share Rwanda's successful experience. Vedaste is um, he is a nurse and a public health expert, works as a consultant with American Cancer Society at the Rwanda Biomedical Center. He is a national coordination for palliative care and the pain-free hospital initiative in Rwanda. Vedaste has led integration of palliative care and pain management into Rwanda's health system by training providers and improving access to essential medicines like oral morphine. Since joining RBC in 2018, in addition to the pain-free hospital initiative and palliative care, he has coordinated ACS's projects like ChemoSafe and the NCCN harmonized guidelines, while supporting national cancer control efforts in Rwanda, which is very successful. He also leads the awareness raising, screening, and early detection of other cancer related works. Vedaste previously has worked at the Butaro Cancer Center of Excellence as the first nurse in Rwanda to administer chemotherapy and lead as deputy nursing director. He contributed to multiple researches, publications, and presented internationally and nationally. And he completed his master's in public health at Mount Kenya University. Vedaste, the floor is yours. Thank you.
Thank you, Janet, for the great presentation. So I take also this opportunity to welcome my colleague. So from different countries, especially my colleague from Rwanda. So I'm glad that I'm seeing among the audience that we are with the director of nursing from different hospitals in the country. So where we have been working together to implement this successful program like the Pain Free Hospital Initiative, and the other colleague also joined. So I think this will be an opportunity, of course, not for myself only, but from the other participants to share the experiences, challenges that they have been facing throughout this program, especially focusing about pain management and palliative care. So I will take some minutes to talk about how Rwanda has been implementing the Pain Free Hospital Initiative. And I think we also have the time to ask questions and also to share the experience. Next slide. Next slide. So after this presentation, so we will hear about how Rwanda has addressed the challenge of pain management through the national policy endorsement. And we also talk about how we have been addressing the supply chain of morphine, especially oral morphine solution. And we talk about how also Rwanda has used the staff champion from each hospital to implement a successful project or successful implementation of the pain-free hospital initiative. Next slide. So as you can see, for a short background, I would say that Rwanda in 2013, so we used less than 0.03 kg per year of morphine. So, and this probably is a very low quantity, and different reason may be arised or may be behind of this very low quantity. So among them, probably we can focus about what Janet has also mentioned. Sometimes you can relate it to lack of access to pain relief, especially morphine. So we can think about the lack of awareness among healthcare providers, doctors, nurses, patients also. So we can also think about the opiophobia. If I say opiophobia, so I'm lucky that here I saw many doctors in the audience. Sometimes doctors feared from prescribing morphine. So because of different reason, probably the side effect. So a lot has been happening, especially for opioid use. So in Rwanda also, before this year, really we used a very low quantity of morphine, and we have tried to calculate the average or like an estimated quantity of morphine which is needed to treat severe pain among cancer and HIV. And then we found probably we need around 40 or 39 kg a year. So which I think we are still, we still have a long way to go, but a lot has been also improved since the beginning. So to try to address this challenge, with the commitment of the government, of course. So we are trying to integrate the palliative care and pain management. So through our Ministry of Health, health system, which start from like teaching hospital to the community, but also we have some package that are being provided to patient in need of pain management, probably or especially home-based care. We have some hospices, and then at each level there is a package. There is a package of palliative care and pain management services which is being provided there, and this is the way is in the way of trying to improve the quality of pain management, but also raising the awareness around pain management and pain assessment. Next slide. So, as I said, we are going to also to list what the government has been done, especially in national policy endorsement. And because we will be discussing, so each country probably may have some challenges different from the other country. But in this process of improving the pain management and the quality palliative care, so we can't ignore the role of government. So in Rwanda, I would say that the willing of government to prioritize the pain management and palliative care was also among our key priority. So the reason why in different policy talking about cancer, we have been including the pain management and the palliative care. The first one, which is standalone, was a palliative care policy that the government has signed. And among this palliative care policy, there is also a pain management guideline where each hospital has this have access to this policy to implement the palliative care and pain management. And we have also integrated the palliative care into cancer control plan. So now we have a new 5-year national cancer control plan, and we are lucky that also we have included the palliative care and the pain management, which also brings the awareness for the community, for healthcare providers. And Rwanda has also adopted to integrate palliative care and pain management within the non-communicable diseases treatment guideline. So what if nurses and doctors are being trained on NCD management? Why not can't we also train them about palliative care and pain management? So we have also been able to include this policy, and palliative care and pain management also is within the policy. Next slide. So with the effort with the Ministry of Health, because the pain now is among priority. So I said that I'm lucky that I'm with the director of nursing and midwife from different hospitals. So there is something which is very, very positive to the community, because the Ministry of Health has included the palliative care and pain management or pain assessment and appropriate pain management among the pre-existing policies that the ministry used to evaluate every year from all hospitals in the country, especially public hospitals. So now the pain assessment, pain management, and appropriate pain management is now among the list that the Ministry of Health on regular basis evaluate for its implementation on a regular basis. So this is also a sign to show that pain and palliative care is a priority in the country, and the Ministry of Health also recognize this pain as a patient right, because pain management is a patient right. Of course, the Ministry of Health needed to fight against that. Is being implemented? Do patient get treated from pain? So this is also among the achievement, and it shows now how the government really have this willing to support and improve the pain management within Rwandan health facilities. And of course, we are working with the rate of nursing, the hospitals to support integration of pain assessment as a five vital sign. So if I say this, before we collaborate with the American Cancer Society in 2018. Some practice were missing to consider pain assessment as a vital sign. Nurses used it to assess other vital signs like blood pressure, pulse, temperature, but they leave behind pain. So now, because we are raising the awareness about having this pain being assessed, to be sure that we are really giving pain medicine appropriately means we are basing to the pain score to provide medication. So now it is becoming a habit and a routine activity in most of our countries. So and then the government has also developed a package of community health workers. So in the country, most of our activities, we have many activities related to health, where community health workers play key role in managing different cases in the community. At the moment now, government has developed a package of palliative care to be implemented by community health workers in the community, because we found that most of our people, they needed to die at home. But what if they are discharged at home and there is no one to take care of them? So the reason why the Ministry of Health and the government of Rwanda wish to include at least a small package of palliative care that the community workers can provide at the community level. Next slide. So coming back to the second objective, which is supply chain. So you find that we used to consume a very low quantity of morphine. And if we are raising awareness about assessing pain, if you assess pain and then you find the patient need pain medicine, of course you need to provide the medication. So what if you have stock out? So that is also a challenge. But in Rwanda, I would say that since 2014, so we have tried to make our local production of olamorphine solution. And before that, the Ministry of Health has included, under the list of essential medicine, they have included the morphine. So as an opioid, but also because we know that morphine is a medication of choice to treat severe pain, the Ministry of Health has listed this medication under the essential medicine. If I say essential medicine, it means that we need to have access to this medication, to procure the medication, have access to this medication. But after access, we need also to think about the affordability of this medicine or by vulnerable people or by everyone, regardless of any social constraint. So, and then in Rwanda, we have an agency which is supplying all medication in the country. And of course, we are lucky that the morphine is really among the list and among the lot of medicine that this entity is making sure that the supply and procurement is going well with this medication. So as I said, you have this local production of morphine, oral morphine solution since 2014. Next slide. So if you can see, the awareness has been also increasing, and we have adopted to train all hospital pharmacists to make sure that these pharmacists really they know what about pain, they know importance of pain, and they know which impact and how can impact having a patient without morphine and is in severe pain. So now they have been trained, all of the public hospital. We have the list of pharmacists who have been trained to make sure that this medication is constantly available at the hospital from central level, from the unit of production to central level until the hospital. So they are controlling this channel, and they report on a monthly basis to make sure that the hospital have access to this medication. So with this awareness, we've improved the supply chain. So we have improved from 190 bottles to 23,000 bottles. So even if you can see that there is a great improvement, but we are still we are still far from where we need it to be. But this also is something that we are glad for our country with the effort that they are putting in to get access to medicine. So currently, I can tell you that 100% of public hospital have access to olamorphine solution. And I would add that at the moment is free from charge. So they get this medication free of charge to make sure that everyone can afford this medication without any constraint, any social or financial constraint. And for the sustainability, the government adopted now to plan every year a fund to procure morphine powder for the sustainability because sometimes we have been working with Hospice Without Borders and we are glad that they have been supporting us even until today. But the government now has allocated the budget to procure morphine powder for the sustainability. We are also glad for this achievement. Next slide. So we have also tried to educate the healthcare provider on the supply of medicine. As I said, the pharmacist has been trained on how they can continue to make easier the supply. We used to have some different workshops to work with hospitals, pharmacists, and staff champion to make sure that this medication is there on time, on timely, and when we need it, it is always available. Next slide. So as our third objective about the training of how we have been implementing the pain-free hospital initiative. So I'm also very glad that we are with some staff champion currently on the call from different hospitals. I can't imagine how much you have been doing a great job to make this program to be successful. And I really thank you so much, you guys, different staff champion from different hospitals, director of nursing. So this was a journey, but I know everyone has been playing a key role to address this, to be a successful, to implement this project successfully. So at the beginning of each hospital, from each hospital, you had one medical doctor, we had one nurse and one pharmacist, and you can hear that the one medical doctor was there to help in training, make sure that the prescription is going well, make sure that other medical doctors are also attending the training. The nurse was there to facilitate the nursing in the patient assessment, pain assessment, regular awareness, education. Pharmacist was there to support in availing medication always. So this team from each hospital, really you have been playing a key role. So the reason why now pain assessment, as I said, is now becoming a routine as a vital sign. Doctors has been trained and this staff champion from each hospital, they were also the one to train their colleague. They were the one to train their colleague from the perspective hospitals. Next slide. So you can see that each year we had a different batch of training, and this was done on-site training. If I say on-site training, that means this staff champion were there as trainers for their colleague, and then the RBC and the Ministry of Health sent some mentee or mentors to work together with this staff champion to run the on-site training. So we have been now able to cover this number. As you can see, every year we have been able to train. If I say training, is not having like a specialist, but at least they are aware of pain, they are aware of the good pain management, and they know they know the importance of pain treatment for cancers and also other NCD patient. So I would say that the awareness has been improved, and with the American Cancer Society, we said that probably we need also to roll out the online course when the face-to-face is not feasible. But we have been able now to launch the e-learning pilot. I know director of nursing who are here, most of them has participated in this e-learning pilot. So, and it was really very good. and successful. And I'm glad that we are very soon going to bring again the other phase, which now will certify them as people who have completed the all online session on pain management. Next slide. So having this initiative and also training medical doctors, training nurses, assessing pain on a regular basis, the awareness has been increased. Patient knows now to report pain. They know that it is their right to say that I'm having pain. So all of this combination of effort has made our country now to improve in what we call pain score. Because at the beginning, I would say that we're scoring about 7/10, and now we are scoring 3/10. That means that at one hospital, you can go and you assess a patient, you find he has a severe pain. But in the majority of that, will not have a severe pain. And if someone has a severe pain, we will also have access to pain medicine. So this is an effort that you have been making together with the staff champion, together with the American Cancer Society, together with the Ministry of Health and the Rwanda Biomedical Center. And we are really grateful for each effort from everyone. So next slide. I would say that I thank you so much, and this will be a time for question, input, yeah, experiences, something else. I thank you so much.
We have a few minutes for questions. Emmanuel, I saw your hand up. Would you like to come off mute and ask your question?
Okay, thank you very much for this opportunity to speak. For me, it's not a question, but it's a compliment to my colleague Vedast, who just finished to present. Thank you very much. Good afternoon, good evening, and good morning for where you are. Just for a quick reaction on the previous presentation. Of course, at Butaro, I'm just Emmanuel, Director of Nursing and Midwifery at Butaro Level 2 Teaching Hospital, currently the Cancer Center of Excellence. At Butaro, I can give some experience. Of course, treating pain is not just a risk. It's just a basic human right and a part of caring patient with dignity. So at Butalo, we treat many patients with cancer, and we see every day how many patients with cancer. I have an example. For example, in 2015, we had a patient with severe pain, but at that time, the oral morphine was not available. Despite of effort, suffering a lot. So the moment it was very hard for us to support the patient, but it was an experience, and we learned how we can support our patient and for even for future. So for now, at Butalo, we were lucky that we are the first champions who initiated the patient file, including pain assessment, like other vital signs, like we measure how patient is having pain, and even like other blood pressures and temperature. So we also trained our staff on how we assess patients, and we also provided some oral morphine because at the time the oral morphine was available through the pain-free hospital initiative. And our patients were very improved, and patient could sleep, eat, and enjoy time with their family. And also, for us also, we are happy for that. So, you know how patients were getting the dignity for that support. So, pain relief help patient with to live better, family feeling, not stressed, and even healthcare system is gained truth. So I know as all of us here present, the key message here we can take home, of course we are thankful for our government and even for our Center for Health, like RBC, where Vedas is working for. So all of us at the hospital in Rwanda, lucky to have to have them to have the initiative, the pain-free hospital initiative, as a program which is supporting us or supporting the government to assist the patient. For example, having that olomorphine, as even the United States, yeah, for our patient, they get it for free, and we don't have patient with for suffering such pain as even the previous. So I think if I cannot take long, a health system that relieve pain is the health system that care with dignity. Thank you very much. Over to you.
Thank you. And we have time. I know there's some questions in the chat as well, but I do see Budori, if you'd like to ask your question, and then we will transition to the case portion. Thank you.
Hello, 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 hello.
We can hear you, Budodi. We can hear you.
Okay, thank you. My feedback is positive. Now I want to appreciate the presentation of Monsieur Vedaste. Now it is really very appreciation that it was a long journey, it was a struggle, but now it is a good step because my name is Budere Aphrodite Nas from one hospital in the rural area. But what you have to say, it is a good step in Rwanda. But even all hospitals have the system for managing pain. We have the drugs, we have the policies, the patient are well managed. It was a long journey, it was a long process, but now it is a very good achievement. We need to appreciate and we need to say merci to Monsieur Vedast because he has struggling with that activity. It was a long journey. He worked along across all hospitals or areas across the country, but now it was a good step because the patient from Rwanda are well managed. We do not miss. We have a stock of morphine. We have a policies. The nurses, doctors are assessing pain, are managing patient according to the protocol. Now it was not saying long things, but we need to say merci and thank you for your presentation. Thank you very
Thank you
much.
so much.
Mm.
And then I will get the case study slides put up, but in the meantime, Videst or Gannett, there's a question in the chat. How many champions per hospital usually, and what do you do with attitude? A common complaint we hear about health workers. How is feedback provided when pain assessment and management is not very well done?
Yeah, thank you so much. I would say that, as I said, from my experience in Rwanda, we had three staff champion. As I said, one was one medical doctor, and second one was a nurse and a pharmacist. So this one, they are the one who were like they were hospital staff champion to make sure that the pain free is being implemented at each hospitals. So if I would say with the attitude, because you have been able to train everyone, so of course the knowledge, attitude, and even skills were improved. And they are the one now also to make sure that what they learned from the TOT training of trainer, they are what also they are providing to the colleague at each hospitals. So about the pain assessment, of course, there are some challenges behind because people were not taking pain assessment as something which is really necessary because in Rwanda also we had some in Rwanda we said ihangane ihangane, it's like be patient, be patient. So that operation also used to be it happened where we can find a doctor or a nurse talking to the patient saying ihangane, be patient. However, there is a medication. So now we had to make sure that these staff champion they are there to raise awareness and also raise their voice to make to tell to the patient that you have a right to be treated, but also on regular basis, nurses, doctors, they have been also changing the attitude behind the pain assessment. Until now, it is commonly assessed, and also the pain management is mainly assessed, even in the procedure, even during the procedure. I would say that minor procedure like when we are addressing wounds, Now, before, sometimes patient or children were crying during the wound dressing. So with this change, really, most of the hospitals now they are making this wound dressing as an example without pain. So I would explain a lot, but the attitude and the knowledge and awareness has been improving until you have it successfully. Thank you.
Thank you so much. And then we will have our team try to address the other questions in the chat. But at this time, I'd like to invite Paulette back to provide an overview of the case we received. Paulette?
Thanks, everyone. Thank you so much. I think this session has been really interactive. I see a lot of engagement in the chat, potentially a testament to how connected you've been, Vadas, with your team, and also how important this subject is. Everyone here has experienced pain, potentially not as severe as a cancer patient, and so it really is a thing of dignity. So we're gonna just quickly jump into the case study. I think one of the values of ECHO is that we're gonna have somebody talk about, we're gonna present an experience. This time around, again, the folks who submitted a case have chosen to be anonymous, so I'm presenting on behalf of our providers who have kindly shared cases. Again, the challenges sort of fit into these main buckets here, which is limited availability of medicines, either that they're hardly ever there or that the supply is inconsistent. And then we have patient knowledge and lack of adherence, lack of institutional guidance. I think patient knowledge is something that we've talked about a little bit on the call, but more so what Vidas' presentation and Ganette's general presentation have also flagged is, sort of the knowledge gaps within staff. Again, the solutions, we've also sort of touched on them. I think again, Rwanda is a great example. I'm going to start from the bottom. Rwanda is a great example of how you address financial constraints by getting the government on board to cover the cost. And then again, that continuous medical education. I like the last example where Vadas was able to share. And instead of asking people to be patient, you're evaluating their pain and providing services for them. And then ongoing mentorship as well for staff. Preparing and distributing guidelines, again, really critical because it helps people know what they should and should not do. And then patient education and awareness of side effects. So many people are out there really believing they shouldn't have access because of the fear of addiction, but like, how do you address that? Is where that really comes in. And then again, how can we support pharmacy teams? This is potentially government, but I see here that they're, quick, innovative slash, what's the word? It's skipping me. So basically, again, learning how can we use what we have and borrow from facilities who may have a little bit more than we do, and prioritizing patients with severe pain. I think that last one is kind of interesting because again, it also is linked to continuous assessment because that's the only way you're going to really know those in severe pain. So we're going to discuss as we go into the next slide, please. And just feedback we have. We're going to focus on this case study that's highlighting a nurse's experience with, meeting with assessing and managing the pain of a patient. Again, we're going to look at the challenges they face, the solutions they applied, and hopefully, whether through chat or going off mute, we're going to try to discuss and hear from everyone what feedback you have, either adding to their solutions or making additional recommendations. Next slide, please, to what they already shared. So again, we know that providing cancer care is very interdisciplinary, and while there's conversations going on, it seems that it's insufficient, right? And so the solution here was is to continue to use those multidisciplinary tumor boards and multidisciplinary sessions to integrate holistic care. Again, as you go off mute or as you use the chat, if you can share some experiences with your multidisciplinary teams, how you collaborated to integrate pain management strategies effectively, that would be great. Whether it be assessment or access, things like that. And then the next thing is documentation. Again, I think we see this across several healthcare conditions, but this one has to be an area where it's really critical because you're not going to know what the last thing the patient said if you didn't write it down, right? So inconsistent or incomplete pain documentation can really hinder whether you're tracking the patient's needs and following appropriate mechanisms for reassessment. So again, the solution this case presenter used is, again, exploring ways to enhance consistent documentation and reassessing the pain to monitor treatment efficacy and to make timely adjustments. And then if, as we discuss, what some of the, if you have any innovative or evidence-based tools and approaches that you have used to more accurately document, track, and implement patient assessments, pain assessment, that would be great. So please, again, use the chat, go off mute once we start to have the conversation. And then the final one is the patient fears and beliefs. I've heard people say, having done this work as well, I've heard people say, oh, I don't want to start at all because I don't want to get addicted. The thing is, part of managing your treatment is the pain. So, again, concerns around tolerance, addiction, and some of the side effects as well. And then on the reporting of pain, because folks are reluctant to communicate or to even accept that they're in pain. So again, this case has taken advantage of communication strategies to actively listen to patient complaints, but also to validate their experiences and to educate the patients and their families that pain management is part of patients' treatment, right? So again, that dignity of services. So again, as we go into the discussion, what are best practices for ongoing training and education programs to address knowledge gaps with patients, with colleagues, especially with provider, and again, strengthen provider confidence that, given a patient who's in pain, opioids is not going to, get them addicted because they're already in pain, right? And what the protocol is to manage not having that be an issue. And then again, how do you also provide non-opioid pain therapies as well? So we're going to go into discussion, and Rish is going to get us to kind of see each other as we have these conversations. And please, we want to hear from everyone on the call who has had experience. If you've done anything different or similar to what the case presenter shared and you have additional recommendations, please feel free. I see a lot of representatives from Rwanda who may have experience that's slightly different from the two who came off mute right after the presentation. I see folks from Nigeria, from Ghana, from Uganda. Yeah, let's have a vibrant conversation about how to support our patients with a major component of treatment that sometimes goes unaddressed. during the poll, some folks, or at least there were 3 people who identified as palliative care specialists. This is an opportunity for you to tell us some of your experiences with addressing these, either based on the case or if there's any other recommendations you have for how they address. Again, it's conversations, communication with the teams, or else we're gonna start calling folks who we know have been part of this program for a very long time, especially because it's one of ACS's oldest and most successful.
I see in the chat that someone has added that in Uganda, there are still challenges for palliative care integration, essential drug stockouts, and no standalone PC policy. That sounds like a lot of the issues that Vidas, I know you touched on in your presentation and might be, valuable going forward after this call to collaborate and share advice and guidance.
Absolutely.
Yeah, I do think always we learn from each other. So, and this is opportunity. This is a platform that we can stay in touch and we share our experiences, supporting each other. So, I'm glad that everyone will need probably to learn from what has been done, even if we are still working and we have a lot also to improve. But otherwise, at the moment, we have something that we can share. So, we'll be happy to share with anyone who is willing to be in touch.
Great. Thank you, Vidas. I see some other conversations in the chat. A couple people are highlighting how doctors are yet to embrace the need for palliative care. I see folks from, and then someone else from Uganda has also confirmed. So, do we have any feedback, recommendations from those on the call? The doctors on the call, what would you say is the challenge with some of your colleagues? And if you have any feedback on how you overcome it, that would be great to hear. How do you encourage your colleagues to recognize that pain is part of providing care? I mean, we welcome other providers as well who can chime in and give recommendations on how the doctors can further embrace the need for palliative care.
Palet, may I respond to the statements of Uganda?
Mm-hmm. Of course.
Yes, good afternoon, everyone. Good morning. My name is Rinti Kintu, and I work as a consultant for the American Cancer Society, and I'm based in Uganda. For Uganda, it's definitely a challenge with doctors who have not yet embraced the need of palliative care. There's a lot of focus on curative care, and palliative care is not yet fully integrated. However, the Ministry of Health does have the requirement for several levels of hospitals, including the regional referral hospitals, to have palliative care specialists. So if you don't have a palliative care specialist in a regional referral hospital, I would recommend to reach out to the Palliative Care Association of Uganda, PICAO. I have seen Lisa from PICAO is on this call as well. Honest, please reach out to PICAO and we make arrangements that palliative care specialists get assigned to your hospital as soon as possible. Because there is actually the policy to have palliative care specialists in the different hospitals.
Therefore, you are doing your top perfect. Okay, Mr. Ake, I just start.
Sorry about that, Rinti. Were you still speaking?
No, I think I was at the end when that happened, so that's okay.
Okay. All right, great.
Yes, thank you.
Thank you. Please go ahead, Tadali.
Uh, Thank you very much for the interesting talk, and this is a very timely discussion. Um, so I am basically a pediatric oncologist working in Butaro, Rwanda. So what I see here is doctors are engaged in palliative care in a structured way. Like the undergraduate medical students will have an attachment to the palliative care. That's interesting. So in-service training, be it for midwives or other nurses that are taking care of non-communicable diseases in general, including cancer, shall have in-service training while they are being deployed away from their university. That is a very good strategy that I have seen, and it shall be a blanket coverage because the most interesting thing that I found in Rwanda, whenever patients are visiting our clinic, everyone has morphine at hand, and the patients do know the importance of this thing. So, and the supply, as it has been said, is sustainably available. So sustainability and blanket coverage of trainings, starting from the primary health unit till the comprehensive unit is very vital. And at the end of the day, going back to my country, we are barely, administering morphine. In fact, we have several issues, the supply management and this opioid phobia, and we're treating pain. We are not as such grading pain, and even then, we are not using morphine in my experience. So the behavioral change, awareness creation is very vital. I think it should be done at each segment of the health facility. Thank you very much.
Thank you. Thank you so much. I see the chat is also blowing up, but just to reiterate, what I'm hearing is that there's need for in-service training, but also went through the schools as well. So this is something that hopefully some of you who are discussing the lack of palliative care can start to work with your government on how to make that happen. I also see that there's conversation around leveraging palliative care nurses. There is some conversation happening in the chat. And so again, you know, we're it's good to see that there is an example in Rwanda that we can learn from. And again, that's what these sessions are. Now you have that's detailed, and hopefully there could be an exchange of learnings across the countries on how to move these processes that Rwanda has actually made significant progress in. What can we learn from it? But again, just going back to the case, is there additional feedback that we can provide? I see in the chat, there's another one from Nigeria. Palliative care unit is newly developing and is yet to put forward their rolling up a proper acceptance. Morphine use is very well adopted in my department, hematology and blood transfusion. That's great. Morphine is fairly accessible in the hospital, but very expensive in pharmacies outside. I once lost a patient when abused morphine after discharge from the hospital. So can we get to this as well? Because this may be reinforcing this, and we need to address this. So one patient, who abused it could mean that then there's a need for additional training. Does anyone have experience, anyone who can share around how to educate patients who actually have access on how to manage it appropriately, and so that we're not using this one story to say folks don't need access, right? So it's a combination of things, that we have access to the medicine, we train people on how to use them appropriately. potentially continue to assess pain. Yeah.
Yes, Paulette, I can respond
Yeah.
a little to that.
Thank you, Rinty.
It's very difficult when a patient abuses opioids and you lose that patient because you feel really like, what have I done wrong? I think what is very important is that the prescribers and the nurses are trained well and also educate the family well, educate the patient well about the risks of overdosing without making it really an big issue that people start to fear. So there is really need to train the health workers on how to communicate and then educate your patients on how to best use it. You cannot avoid it 100%. Narcan is not widely available in African countries, leave alone in home situations. So that's very difficult if you have that case. There are different types of opioids and different types of morphine. And the oral liquid morphine, which we have been trying to integrate in the health system in Nigeria as well, together with the Ministry of Health, doesn't have much risk of opioid abuse and opioid addiction and overdosing. So that's a fairly safe form to use at home. But it all comes back to educate, educate, and educate. And in our updated Treat the Pain curriculum, our e-learning curriculum, which was recently launched, we also really go into that to know the difference between abuse, addiction, and dependency, and how to recognize the different states and how to react to that. But it's a difficult situation. If you really lose a patient due to an overdose or abuse, that's very difficult. But it's about education mainly. Yeah. Thank you.
Thanks,
I hope
Rinty.
that
I
answers
see.
the question a bit.
Yeah, thank you. I see Daniela has a hand raised. You're on mute, Daniela, if you're speaking. Yes, go ahead.
Thank you so much. My name is Daniela Atlot. I'm consulting with Bukau on this project. My question is, how do we get the doctors involved? I remember we visited two health facilities, that's in St. Francis Hospital in Zambia, and we interacted with the nurses who were on the training, but only one doctor was participating. So how do we get the doctors involved in pain management? This also goes to Vedaste. How did he get the multidisciplinary team working? Because that's a challenge. And secondly, I'd like to know how the government was involved in morphine production here. Like one is highlighted is we are having issues with integration. The Ministry of Health is advocating for integration, but us as PICAO, we are struggling to find ways of how to integrate palliative care into the health system. Currently, it's we're training uh, palliative care nurses at Hospice for Africa. There's an institute there, and we are managing where we're applying for accreditation right now, but we're still lacking that recognition. So how do we integrate palliative care, especially pain management for cancer patients? Because recently I took a patient to one of the health facilities, but they didn't believe him, and yet a month, 2 months, they've actually found out that he had cancer, and yet when he was presenting with issues, they actually sent him home. And these are the doctors. So how do we get doctors on board? Thank you.
Thank you,
Yeah,
Daniela.
thank you so much, Daniela. So I would try to answer to your question. First, as I said, there is a big role of the government in each step. So because even a medical doctor can't even go to do something which is not supported by the government. Let me start from there. So now if I started presenting with the national policy, that was to make sure that a national policy goes with the government willing to support something. So if we are going to talk about pain management palliative care, medical doctor, always they are relating to a guideline which is there, probably from the WHO, from a national document. So Daniela, the first step is to advocate for national document or national policy which bring attention to medical doctors and nurses in health system. Because if in Rwanda we don't have national palliative care policy, if we don't have pain management guideline, so everyone will escape and will not take this as something which is very important. That one. Second, so raise awareness about the need of pain management. So, like pain management is a patient right. This is not a word from Rwanda. It is a word from WHO. So why other countries can't make sure that they are fighting against the patient right, which also include pain management and palliative care. So why a doctor is there and doesn't treat pain, however, the pain is a patient right. You see, so we needed to work together as a multidisciplinary team. Everyone needed to play a role in raising awareness first among healthcare providers, including doctors and nurses. So having this pain first initiative in Rwanda, as I said, we had the three staff champions. Among these staff champions, we had one medical doctor. So that medical doctor is there to raise his voice and to bring on the board their colleague as medical doctors. Because if I had nurses only there, it would be also a challenge to convince medical doctors to come on the board. But having a medical doctor, having the director general, having clinical director involved in this involvement, now we have seen on a daily basis some doctors are coming to attend like the training. Now we find that can be feasible. And you have the policy which asks doctors to prescribe medicine. And you have medicine. The medicine is there. So who else will prescribe medicine apart from a medical doctor? So, but it is a journey. But together with advocacy, always it is a challenge. It's a process. It is a process. Today, tomorrow you advocate again, and then it is a process. And I'm glad that at least some medical doctors have been familiar with prescribing this medication, so it is not a challenge in the country. However, there are other people who are not, who even can't prescribe this medicine because that opiophobia is still yet there for some doctors, especially the one who had graduated many years ago. But the newcomers, doctors, now they are coming with this course. They know how to prescribe medicine. They know how pain is a patient right. You see, it's very, very easier. So I think we need advocacy, especially from the national level to implement some national policy, which include the need of pain management and which details the involvement and the role of medical doctors in this process. So before I hand over, I want also to add something on what Rinti mentioned about the abuse of morphine. So even if the question was asking about abuse in the
Mhm. But I say we can hear you.
community. But even in the hospital, you can have reducing this risk. We need to do the pain assessment. The reason why we present, I assess a patient and I find that he need or she need morphine, and I give him morphine because I have tried to assess the pain. So the pain management, the pain assessment goes with the pain management. So that's what I want also to highlight about this. The need of pain assessment goes with the appropriate pain management. Thank you.
Awesome. Thank you so much for that. And thank you. This was such a rich conversation. There's additional feedback and conversations in the chat. Again, examples of some doctors who have experience from training. It really sounds like what Badas said. Once you have to carry the doctors along when you're doing the training. And for those, and we have the survey up right now, please, as we're coming to the end, just take the time to respond to the survey. It really helps us to understand who's here, what you're getting out of it, and each session survey is actually specific to the session. So please help us with completing those. It really helps with the process. If I can
Can I
just,
add one point, Paulette, before the end?
yeah, of course, yeah.
For the last question about involving the doctors in the
Uh-huh.
training, I know some doctors are very busy to sit on in-person training. the online training is very helpful for them to take it on their pace, as well as we have a short self-learning material which creates awareness, which you can send it to their email so they can read it at their own pace. That also helps.
Awesome. Thank you so much. So I think there was a doctor on the chat, Dr. Chidiadi. This is an opportunity for you to get access to an online version that you can disseminate with your teams. And really just how can we, first of all, those of you who believe in it, do the training and then cascade to your colleagues. But this was a really good conversation that I hope doesn't end here, that continues to go on at your facilities, and that you're reaching out to the ACS platform and the ACS team to get access to these resources. And Vadas is available, to share all of his fantastic experiences and give you nuggets. But I must say that working with the government is critical. In my experience in Nigeria, just having that government backing and having a policy really made a world of a difference, including getting doctors. So, as Vadas said, advocate, 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 and we can see this change for everyone. So, thank you. I'll hand it back to you, Rish.
Thank you. Yeah, this was absolutely great. And I know it can take a little time to get comfortable in the group setting, but thank you so much for Paulette and Videst and Gannett, all of your leadership in today's meeting, and really all of you. Thank you for sharing your experiences in the chat and in the group setting. We do have one more session that will take place at the end of October. But for today, please use your phone or the link that Justine put in the chat to complete our brief short session survey. I don't think we have any that have been submitted so far. Our evaluation person is kind of watching to make sure we get some responses rolling in. But again, this really helps us to determine what next steps will look like as we build out these programs. We want to make sure that they're really tailored to you. So I'll leave this up for just a minute longer. I think we're starting to get some surveys rolling in. Um, and again, I will go ahead and just resend the link in case some of you are joining from your phones. And then we also will send a follow-up email. As we mentioned earlier, we will have the recording of this session and these slides available on our website. And then we will also share a follow-up link where we will include a, um, a case link. So that way, if you want to submit a case for the next session, you are more than welcome. Very quickly, I will, oops. Here is a QR code, and you will be able to use this link to submit the call for case studies. So if you want to um, submit a case on the topic of ChemoSafe with Dr. Korantang, please go ahead and do so. We would love to hear from you. If you're not comfortable speaking to the audience and presenting a case, you're welcome to submit anonymously. But if you are feeling bold and brave, we would love for you to present your case, and I'd be happy to help you every step of the way. I know we are starting to get a few surveys rolling in. And so with that, I will kind of leave this up. If there's any, I know we are at time, so thank you guys so much for joining us today. And we hope to see you at our session next month. Thank you. And Justine, are we still recording?